Now, the next point which we are discussing would be about the reactive arthritis, which is a broad but a controversial term. Reactive arthritis is a very broad but a controversial term which is often used in the regular practice. And by definition, again, nomenclature of reactive arthritis is a again changing phenomenon. The current definition of reactive arthritis is just like earlier it was considered as Richter syndrome, and it's an autoimmune condition that develops in response to an infection anywhere in the body. If there is any infection, if there is autoimmune response by the body, and that results in arthritis like symptoms, that's considered as a reactive arthritis as such. That's one of the major definition as of reactive arthritis. A classic triad of reactive arthritis symptoms, and it's seen in only one third of the patients having arthritis and pain in the joint, conjunctivitis. But in majority of the patients, it's only in 30% of the patients that you see all these three set of symptoms together, whereas majority of the patients would have only the pain in the joints as the major clinical presentation as such, and it could be produced due to established factors like gastrointestinal tract infections, Shigella, Salmonella, Campylobacter and other organisms, as well as genitourinary infections. As it is that many of the viral infections also can produce the reactive arthritis, like chikungunya and your dengue, etc. They also produce the symptoms of pain in the joint. Majority of the viral infective pathologies in the initial febrile stage, the patients present with the pain in the joints, this also is a reactive arthritis as such. The typical definition or maybe identification, clinical identification of reactive arthritis is when there is acute onset of reactive arthritis. Most of the time the symptoms would occur suddenly and without any specific or rather classical history. It's most of the times there could be a preceding illness which suggests of some infective pathology like fever, fatigue, or some fever as such, mild fever many times, or different varieties of the symptoms. Most of the times you will have that kind of a symptom like fever or fatigue as such. Then characteristically it's asymmetrical, and most of the times the patients would have the symptoms in the lower extremity, joints of the lower extremity are involved, and you will not have all the classical clinical sign of arthritis, because the reactive arthritis involves the muscles and tendons. There may not be any effusion in the joint in majority of the patients. It could be just moderate tenderness over the tendon area of the joints. That's why it's called as oligoarthritis. Oligoarthritis, where relatively the symptoms are minor, as the major presenting symptom or myalgias, pain in the muscles also could be the clinical presentation in reactive arthritis. The joint may not be involved. Particularly myalgia produced in the group of reactive arthritis is mainly due to the statin effect, which I will be dealing with at the end of this session. I will be dealing with that part also. Myalgia produced due to statin induced condition, which I would consider as reactive arthritis. Then very frequent would be patients who have gonococcal arthritis, having urinary infection. That's one of the majority of the situations. You will have that patients who have urethra involvement later developing reactive arthritis is common. Conjunctivitis or ophthalmic symptoms also may occur, relatively rare, but it can be seen in a few of the patients. And patients may also have gastrointestinal tract symptoms as such. One of the most important factor of reactive arthritis is diagnosis of reactive arthritis is always clinical, based on the history and physical examination. There is no laboratory study or imaging study which is diagnostic. Confirm the diagnosis of reactive arthritis with a laboratory study or imaging is not possible. And whenever there is any evidence seen radiologically, or it could be like the laboratory investigations, it's not considered as reactive arthritis. But one of the important issue which is seen is there would be some metabolic pathology usually accompanying reactive arthritis, and the most common reactive arthritis metabolic pathology would be presence of uric acid level. Uric acid, now see, uric acid levels, when it is increased remarkably, it may produce a formation of a crystal in the joint, and that condition is called as gouts, where you will have the real involvement of the articular surface of the joint. Whereas a moderate rise in the uric acid levels would be resulting in the edema of the tendons and muscles. The joint surface may not be involved, and majority of the patients of so-called reactive arthritis, which we group them, would be having a moderately raised creatinine uric acid level, and the relationship of the uric acid level with the food habits is one of the most important observation, which is not really mentioned in many of the classical texts, and which we can see clinically in the conditions. And majority of the patients who may see, like patients who consume this fast food or maybe the spicy food, developing that symptoms of pain in the muscles or pain in the joints is also considered as a reactive arthritis. So that's one of the important issue, which is slightly different from what we see in the classical text as such. So of course this issue of diet and the food habits and the reactive arthritis is one of the important areas of new researches occurring throughout the globe. It's not only that me who says about it, but still the information is still in the fluid stage. Like it's not yet in the stage where the information is added to the classical textbooks as such. So it's a bit of controversial issue, but the fact is true. Like it's the diet which is one of the important factor, and relationship of the uric acid with the arthritis symptoms or myalgia symptoms also is one of the most important observation which we see regularly in majority of the clinical conditions in the hospital as such. And that's why majority of my patients, I would be doing that uric acid as a classic this conventional investigation regularly in majority of the patients who present with the pain in the joints as such. Anyway, that's one of the issue. The general prescriptions for reactive arthritis in the elsewhere in the contemporary system would be NSAIDs, corticosteroids also are used, occasionally antibiotics also are used, and now even disease modifying drugs also like methotrexate, sulfasalazine also are prescribed. But what I have seen is, and what we can really see is none of these are essential. We can effectively manage the patients on the line of mamsavaha, like Kaishuru, Mrityunjaya and Amrvarishta. And it's a fact that majority of the patients with these kind of symptoms, they end up in Ayurvedic clinical conditions because there is no objective method of investigation. So contemporary systems would fail to make the diagnosis, and the prescription of the NSAIDs or glucocorticoids etc., they also may not be easily acceptable to the patient, and hence that's one of the conditions which is rather, I would say, bread and butter of Ayurvedic practice. And Kaishara Mrityunjaya gives extremely good results and treated on the line of Amavata. Now another condition which is very close to that reactive arthritis but has a different name conventionally, and many times this also is considered as a reactive phenomenon, is a polymyalgia rheumatica. Polymyalgia rheumatica is a clinical condition which is having complex presenting symptoms, and only after excluding other potential diseases like the polymyalgia rheumatica is a diagnosis, another vague condition. So I would be considering that polymyalgia rheumatica as just a excess of specificity in the nomenclature, but it's also a reactive arthritis only. But instead of it's only in the arthritis, it may present with the main symptoms of pain in the muscles, which also is a typical presentation of the reactive phenomena. So it's a reactive phenomena. Polymyalgia rheumatica is a reactive phenomena, but in the conventional medical practice, you have a separate name given that for a polymyalgia rheumatica is regarded as an inflammatory immune-mediated disease with mixed mechanisms in a background of genetic and epigenetic factors. So in a very advanced method of diagnosis, you may find some genetic factors or immunological and endocrine pathology, often related to the old age. This is how it's defined. But actually, it's not related only to the age, and majority of the patients you may not find any autoimmune phenomena or immunological phenomena in the routine method of investigation. Very advanced investigations may be as seen as such. The exact causes of polymyalgia rheumatica is yet not known, and again, the current trend and maybe the future would be about the diet, about the food as such, particularly the fast food. Fast food would be the maybe in future you will have that established observation like polymyalgia rheumatica is most closely related to the food. And one of the other recent observations, recent studies have confirmed like many viral infections like influenza or COVID-19 vaccination also now are known, and these now are becoming established. So the only difference between what we do as a nomenclature would be in all that febrile conditions and the patient presents with the pain, I would be naming that as a reactive arthritis only. I may not use the word polymyalgia rheumatica, but the other conventional name is the polymyalgia rheumatica. For polymyalgia rheumatica, there is a definite diagnostic criteria that the ESR is more than 40 and age would be usually the older age of above 50, and pain persisting for more than a month and involving the criteria like either neck, shoulders or pelvic girdle, the major joints are involved, then the diagnosis of polymyalgia rheumatica is done. This is about the conventional method of making diagnosis as per the ULR guideline. But in due course of time, this guideline may be changed, that age restriction, that ESR and the duration also may get changed in the other factors. Then the other important factors are absence of other diseases capable of causing the same musculoskeletal symptoms, and morning stiffness lasting for more than an hour, and a rapid response to prednisolone. This is a conventional method again, which we may not use in our clinical practice. We always prefer to use the same, the mamsavaha treatment. It's also another category of mamsavaha. But the most important part is absence of other diseases capable of causing the same musculoskeletal disorders. So once you have ruled out all the other diseases which can produce the pain, then the diagnosis of PMR or polymyalgia rheumatica is done, which I would be making the diagnosis of a reactive arthritis. The present latest information about that guideline about is by the ULR guideline in 2012 is a provisional classification criteria for PMR as aged 50 years older or bilateral shoulder aching and elevated inflammatory markers. Inflammatory markers like cytokine level also being raised is one of the newer added conditions, and the modified 2012 modification of the guideline is a morning stiffness of more than 45 minutes, then the point would be 2 point, hip pain limited and range of movement of the hip is 1 point. Many times it could be in the back also. Many of the patients who often may present with the symptoms of typical lumbosacral pain, which we often make a clinical diagnosis of disc lesion, may have this PMR, polymyalgia rheumatica. When radiologically everything is negative, but the patient has a backache, you may make the diagnosis of polymyalgia rheumatica. And the most important is the other investigations becoming negative, and the absence of rheumatoid factor or the anti-CCP factors and peripheral joint pain being absent also is another classical diagnosis of polymyalgia rheumatica. And the current guideline, the 2012 guideline, is if a score is more than 4, then it has a 68% sensitivity and 78% specificity to make the diagnosis of PMR. But I think this kind of a rigid criteria is not necessary. You may make the diagnosis of the reactive arthritis relatively easy, and a broader term of reactive arthritis is quite safe and effective, and it can be easily managed. Systemic findings also are seen in more than 50% of the patients, and the usual clinical systemic symptoms along with the pain in the joints or the muscles would be a low grade fever and weight loss, malaise, fatigue, which are generally considered as vague symptoms, and difficulty in raising from the bed in the morning, or difficulty in getting up from the toilet or out of chairs. Vague symptoms. It is not really, you may not have all the signs of arthritis, but due to the rigidity of the muscles, these kind of symptoms do occur, and difficulty in completing daily life activities like climbing the stairs, etc. Morning stiffness for more than 1 hour, often or more prolonged. Muscle stiffness after prolonged inactivity, like sitting for a long duration, and as you get up from the sitting posture, you may have the pain. Synovitis of proximal joints and periarticular structures. Many times there could be inflammation of the synovial membrane also. Peripheral arthritis, these minor joints like phalangeal joints or wrist joints could be involved around 25% of the patient. Even some of the patients may present with the symptoms of carpal tunnel syndrome, that the nerve root could be compressed, nerve path may be compressed as such in about 15% of the patients. Some of the patients may have a distal extremity swelling in approximately 12% of the patients, and possible development of arthralgia and myalgia up to 6 months after the onset of systemic symptoms. After the episode of febrile illness, some amount of febrile illness, symptoms developing of pain in the muscles or the joints, and up to for a long duration, even up to 6 months, also makes the diagnosis of PMR, which again I would not make into that final classification. I would be including this as a reactive arthritis only. And the other important features of make the diagnosis of reactive arthritis is the muscle strength will be normal, and there will be no muscle atrophy in the initial condition. Only in the very advanced stages there could be muscle atrophy, but such conditions I would not make the diagnosis of simple reactive arthritis. It could be some other diagnosis, because there would be an underlying organic pathology. And pain in the shoulder and hip with movement, and active range of motion may be slightly decreased because of pain. The range of movements may be slightly reduced. Transient synovitis of the knee, wrist and sternoclavicular joints, and more peripheral non-erosive arthritis may be seen in many cases. Majority of the patients we make the diagnosis of reactive arthritis would have this kind of a presentation, where radiologically everything is normal. Clinically there may be a moderate tenderness at the joint area, but no definite effusion. Range of movement may be slightly diminished, or it may be normal, but the patient would have pain. That kind of a symptom is considered as reactive arthritis, which again is mamsavaha. Tenderness on palpation with the decreased active range of motion in the muscles or proximal hip and leg or shoulder or arm girdle. Any of the major or minor joints could be involved. Now, as per the current method, again, polymyalgia rheumatica is considered as a self-limiting disorder. It tends to heal by itself. This is what the contemporary science says. And mainly, if you take care in the diet, particularly the spicy diet, something which is related to the metabolism of acidic substances, and that's exactly the one of the most important criteria is uric acid again. Then the majority of the conditions can be managed without any medicines. But if at all there is a treatment, the treatment suggested in the contemporary science is based upon empiric experiences. It's not a classical treatment, but empiric experiences, and randomized trials are established, and the goal is only to treat the symptom. And among the drugs which are used in the contemporary science are mainly the corticosteroids and the interleukin inhibitors. These are the drugs. The disease modifying drugs also are often used as such. Methotrexate, calcium and vitamin D supplementation is one of the common prescriptions which we see in the patients. But in fact, none of these are absolutely necessary. Patient can be much better or managed much better with our mamsavaha chikitsa kaishara gukula mrityunjaya namrtarishta, which is one of the easiest and comparatively most economical effect of or maybe the mode of treatment. Now, another condition which comes under the same reactive arthritis group, but again controversial, whether the whole issue is highly controversial, that's a statin-induced myopathy. Now, as per the conventional pharmacology and the study of the adverse effects, statin is now being considered as a rather a few years back when the statins were introduced in the pharmacology or accepted by the FDA, it was considered as a safe drug. But gradually, the adverse effects of the statins are now being recorded, and the one of the major adverse effects of the statins is the damage to the muscles produced. Now, as per the available data, uh, these statins may produce the symptoms of myalgia or myositis or a destruction of the muscle tissue. That advanced or a very advanced condition of rhabdomyolysis, where there could be a damage to the muscle, necrosis of the muscles, muscle tissue being dissolved, that would be comparatively less common, whereas the myalgia and myositis produced due to the statin pathology is rather more common, much more common than what these texts would say. See, as per the pharmacological studies or observations, these muscle damage like myalgia, myositis would occur only in around 5% of the patients on statin. But what I have observed is majority of the patients who are on statin, more than 70% of the patients who are on statin, they will develop the symptoms of mild myalgia or occasional myositis. Of course, rhabdomyolysis is very rare. Extreme muscle damage and renal damage occurring is a rare phenomenon, extremely rare phenomenon, which we may not see frequently. Now, statins are prescribed initially for the treatment of hypertension as well as maybe as a prophylaxis for lipid abnormality, hyperlipidemia. But now these days statins are overprescribed, and hence you will have plenty of patients who are on statin, and many times these statins are prescribed in such a way that the patients may have more than one or two varieties of the statins. Maybe as you have seen in patients, in majority of the patients, maybe just a day back, a patient had that 3 varieties of the statins prescribed together, and then we have to modify the doses. And one of the major problem with the practice is the patients are brainwashed in such a way that the statins are essential drugs, and without that the patient would have more serious complications. And to make these or make the patients stop statin itself becomes laborious many times, because the patient may not accept that. So patients who are on statins would developing the pain in the muscles, and absolutely such condition cannot be effectively managed by the contemporary system, and they would end up in Ayurvedic practice. I would often say, like, because the patients are prescribed with these statins, over prescription of the statins, Ayurvedic practitioners are living a luxury life. Otherwise, of course, we may not have that kind of a privilege of having more patients, maybe getting more money, or Ayurvedic hospitals flourish because of these statin-induced myopathy conditions. And majority of the patients, they would develop these symptoms of myalgia, which is characterized with pain in the thick muscles, cramps, weakness, and all other investigations would be normal. Only that creatine kinase may be slightly increased at the level of 170 to 200, not more than that. And many times even this could be normal. And hence, in the contemporary science, this is not included in the damage as such. Such conditions, and majority of the patients whom we treat are of the same condition, which again I would be considered that myalgia as a reactive arthritis phenomenon, and again my prescription would be same, Kaishwaram Mrityunjaya Amritarishta. So when you see more than 70% of the patients treated in our setup having a prescription of Kaishwaram Mrityunjaya Amritarishta, you can make out that the value of the whole issue, making the diagnosis of the conditions, and particularly patients who are on statins, we prescribe the same drug regularly. Then if the patient has gone to the level of myositis, where there will be a weakness of the muscles or even moderate mild atrophy, which is seen in a few of the patients on these statins, and usually the CK level would be 200 to 300, moderately higher, which can also result in the conditions like SLE-like condition, which need to be ruled out, then my prescription would be Chandraprabha Ekangavira Shovintalista. Rhabdomyolysis is extremely rare phenomena. We might not see in many of the patients. And very interestingly, the majority of the patients of statin-induced muscle conditions, now they are diagnosed as vitamin D deficiency, and the vitamin D deficiency, most of the patients would have vitamin D as one of the investigations done. These days, this has become a fashion, study of vitamin D, and a large number of patients of vitamin D are prescribed vitamin D unnecessarily. Virtually, these 99% of the vitamin D prescriptions are absolutely unnecessary, because that vitamin D level either is induced due to statin, that statistical analysis of vitamin D being reduced may be either induced as a complication of the statin prescription, or many times it's simply the overstatement, like the requirement of the vitamin D is considered as something much more than what's normal, that 32 nanograms as listed. In India, where you are exposed to the sunlight at least for 1 hour a day, vitamin D deficiency can never occur unless there is a serious metabolic pathology. Only those patients who have never seen the sunlight, the vitamin D deficiency could be one of the issues. In Western countries where sunlight is a rare phenomenon, or we say a costly commodity rather, where the patients are not able to see the sunlight many times, are extremely cold countries, vitamin D deficiency could be as such one of the necessity. But the awareness of this vitamin D deficiency resulting in myopathy and is now one of the highly controversial issue. But interestingly, in the current situation, the market, statin market as well as vitamin D market is increasing rapidly, and this is also true in case of the Asian countries. It's not only in the Western countries. So in future also we will have the same as per the prediction. The statin prescription market, statin market will grow at a very rapid rate of a compound annual growth rate of more than 8%, and correspondingly vitamin D also will be continuously sold out. But at one or other stage, all these patients would come to Ayurvedic practice, and you will have a highly satisfactory outcome with the Kaishora Mrityunjaya Amritarishta. So Ayurvedic practitioners would have maybe luxury days in coming as such. Future is quite good. Then the last part of our discussion related to the mamsavaha would be about myopathies. Myopathy is again by definition is a muscle disease unrelated to any disorder or innervation of neuromuscular junction, and these conditions have wide-ranging etiologies. Causes could be many, and the general symptoms of myopathy are symmetric proximal muscle weakness, malaise, dark colored urine which is often due to the myoglobinuria, or sensory complaints being absent. The paresthesias are absent, or even tendon reflexes, maybe deep tendon reflexes may be occasionally diminished, but otherwise they would be normal, except in hypokalemic paralysis where the potassium level is reduced, the tendon may be absent. Otherwise in myopathy, reflexes remain normal, and only in very advanced stages either there could be atrophy or reflexes may be reduced. Consciousness is not affected, and the patient may have a papule-like swelling which is called as Gottron papules, which are presented as a pink to violet type of scary areas over the knuckles in case of the myopathy as such. That's about the cassette. Now, myopathy is a very wide condition, and they are classified into very huge groups or multiple groups. One group of them is either hereditary or acquired. Now, as far as the hereditary myopathy is concerned, from our treatment point of view, our clinical point of view, we have very little to do, not much as such to be done as the treatment. Only acquired conditions we may produce some changes in the outcome. And among the hereditary conditions, muscular dystrophies, the patients have myotonia and metabolic myopathies, mitochondrial myopathies. These classification and identification also is a laborious job. which requires sophisticated investigational setup. And most of the times, by the time you make the diagnosis, the patient would have more serious complications, or maybe all his resources would be lost as such, and the patient would be in a hopeless condition. Whereas the acquired conditions like inflammatory myopathies, infectious myopathies, endocrine myopathies, or metabolic pathology, and drug-induced and toxic myopathy. Drug-induced toxic myopathies, of course, the statin-induced condition also may be considered as a drug-induced myopathy or reactive arthritis. That is the issue of confusion. Now, among the immune-mediated myopathies, which we see, are the polymyositis, sporadic inclusion. These names are lots of different names are there, and these can result in rather a big diagnostic issue, but at the end there is not much to be done in the treatment condition as such. So you may have lots of different names of making the diagnosis of myopathy in advanced condition. Often what we see in the clinical practice, from our routine clinical practice, that congenital hereditary myopathies are of not much importance from our routine clinical practice. Majority of the patients whom occasionally we see, myopathy is not as common as other conditions. They are presented in the adulthood, and the adulthood conditions, muscular dystrophies form one group of the conditions, and among the muscular dystrophies, limb girdle pathologies, facioscapulohumeral conditions often we see in the OPDs, and inflammatory myopathies like polymyositis or dermatomyositis often seen. Viral conditions also can present with the myopathy. Metabolic pathology is one of the area where our treatment can produce some change. Muscular dystrophies, inflammatory myopathies, virtually our treatment, or rather the outcome would be extremely poor. So generally I would avoid treating such patients, and if at all the patients demand treatment, I will be prescribing the usual treatment like Ekamvir, Ashwagandha, but the outcome would be poor. Whereas in metabolic pathologies, Amavata Chikitsa like Agni Chikitsa and Ksharamasti may produce some changes, and comparatively the incidence is less common. And these metabolic pathologies from our conventional method, it could be again further classified into acid maltase, lipid storage, or debrancher. Now again, these investigations do not end up with any positive outcome. At the end, you may name the patient with their specific name, and virtually there may not be any change in the outcome. Now, one more area where there can be a significant benefit of the treatment would be endocrine myopathy, like thyroid or parathyroid, hyperthyroid or hypothyroid. Both the conditions can produce the myopathy, and in that condition, prescription of the specific either thyroxine or antithyroid drugs like if necessary, would be the choice of the treatment. And patients with the electrolyte imbalances like hypokalemia, they also may develop the symptoms of myopathy, and in such conditions, prescription of the specific electrolytes can produce a significant change. So, endocrine myopathy is one of the area where the clinical outcome can be significantly modified. Outcome can be much better if they are properly diagnosed and a proper intervention is there. Then toxic myopathies like administration of alcohol, corticosteroids, excess of corticosteroids also can produce a myopathy. Then narcotic drugs like chloroquine, statins, again statin, whether it has to be considered as a myopathy or whether reactive arthritis, anyway the controversial issue which already I have told. In these conditions, of course, withdrawal of those drugs can produce a significant change, particularly steroid-induced myopathies. With our drugs, which we can reduce or stop the steroids, the outcome could be better. But only the issue is whether the steroids can be stopped or not in a specific disease condition. That depends upon the reason for the prescription of the steroids as such. Then the other could be myotonic dystrophies, distal myopathies. These are more of academic interest than really practical conditions. Practically, you may not see much of the patients. But certain of the key facts in case of myopathy, making the diagnosis of myopathy, as well as maybe the treatment point of view, I have summarized instead of going into all that these complex issues. I try to make that summarization as a weakness which is progressing over hours, like prolonged weakness. Possibly it could be toxic etiology or episodic paralysis like hypokalemia. Then weakness developing over days. Patient who have the weakness for months or days together. It could be acute dermatomyositis or rhabdomyolysis or real muscle pathology. Patient who have weakness present for only a few minutes or hours. It could be either toxic or electrolyte conditions pathology. Symptoms developing and persisting for longer period like weeks or months together. It could be polymyositis, steroid myopathy, or myopathy resulting in endocrine causes like hyperthyroidism or hypothyroidism. If the patient has a proximal muscle weakness, that thicker muscles are involved, and the symptom could be difficulty in raising from chairs, getting out of the bathtub, climbing stairs, or shaving or combing of the hair, etc. The patient may not have other symptoms, there may not be any pain, the patient may feel that there is a difficulty in raising from the chair and so on, and the symptoms are vague. If the weakness of the distal muscles, then the patient will have a relatively weaker grasp, there could be problem with handwriting or difficulty in walking, etc. The gait could be abnormal. So that's about the myopathies as such. As far as the treatment is concerned, virtually, as I told you, there is not much of a benefit in the outcome of the treatment except in a few this group of myopathies which we have referred to. And the further details, of course, I think these are not really of practical use. Congenital myopathies, again, they are subcategorized into nemaline core myopathy, centronuclear myopathy, or congenital fiber type disproportional myopathy, or myosin storage myopathy, and non-specific myopic changes. These diagnoses would be based upon only histopathological investigations. A muscle biopsy may give that outcome, and this again doesn't really make out a much change in the outcome of the treatment except for advising or making the diagnosis. That's all the issue. Now, as per the data, the latest data, I have just picked up a few of these sentences from a established data source. According to the study by Colombo, at birth, neonates with congenital myopathy require respiratory support and nasogastric feeding in 30.4% of the patients. Newborn, at the time of birth, patients with myopathy may have required nasogastric feeding or respiratory support, which is a totally different issue of dealing with the pediatric conditions and assessing at the time of the birth, etc. Then, in the 12% of the patients died within first year, whereas 74.1% achieved independent ambulation, they could walk, and 62.9% of patients are considered as late walkers. So, all that outcome with all that advanced treatment would be like there could be a very serious issue at the time of the birth as such, or even the outcome would be very poor as such. So that's about the myopathy, and with that we will conclude today, and we will conclude about these your mamsavaha also conditions. If there are any questions, I will try to answer, and then in the next session, as per the demand, we will discuss about the neoplastic conditions. Okay, there are no questions, so we will wind up today.